Hey y'all, and welcome to When Treatment Causes Harm, Understanding PSSD and Iatrogenic Sexual Dysfunctions. This webinar is designed to educate sexuality professionals on PSSD, which is Post-SSRI Sexual Dysfunction, and related sexual dysfunction caused by medical treatment. This is an asynchronous webinar which is offering AASECT-CE. And if you're interested in that, there is a handout that explains what you need to do to take a little quiz and then send back an evaluation for me, and I will send you your certificate in about a week. If you don't hear from me or if you have any issues with this webinar in any way, please email me at margotmmays@gmail.com. The handout that is given with this webinar will have all of your resources on it. It will have links to everything. It will have all of the evidence-based research for your use and your resources for your clients and patients and students. If you are not interested in the CE, there is an evaluation form that I would really appreciate you filling out, so I will continue to grow as a sexuality educator. So thank you very much, and I really appreciate you learning more about PSSD, and let's get started. So first I want to acknowledge the support of my colleagues who have continued to help me better understand and educate on PSSD and similar iatrogenic sexual dysfunctions. They continue to work tirelessly to raise awareness and educate others, and I am deeply grateful for their information, guidance, and assistance they have shared with me. They are Yasi Parani, who is a researcher and a therapist, and right now she is offering monthly meetings if you are a therapist who would like to talk to other therapists about PSSD, about their clients, client load and caseload. So if you are interested in these, they meet once a month via Zoom. Get in touch with me and I will get you that information. Emily Gray is a researcher and associated with works with PSSD Canada. And there's Dr. Peggy Kleinplatz, who is a psychologist, researcher, sexologist, and just a legend in her field. So who am I and why am I educating on PSSD? I am Margot M. Mays. My pronouns are she, her. I'm a middle-aged middle-aged, disabled, bisexual, cisgender female, currently residing on Tillamook Choctaw land, also known as New Orleans, Louisiana, with my spouse and my many pets. That's my little pictures of Hank and Dusty right there. I'm an AASECT-certified sexuality educator, an IC-certified holistic sexuality educator, and an AASECT-CE individual provider. I have 20 years of first-hand experience living with chronic pain, and my mission is to help those who are also suffering with chronic pain and being affected by it, either that being the patients, the caregivers, or the lovers. I'm educating on PSSD because many people in chronic pain have been giving SSRIs or SNRIs to help hopefully alleviate their pain. This is how I contracted PSSD, and many people have. So I just want to acknowledge the people also on the land, on the Tillamook Choctaw land, that were brought here not by their choosing. Many of them have offered culture and influence that has just made the world so much better, just culturally influenced us. So the content warning. So many of my webinars, I try to be kind of happy and jovial as much as possible, but unfortunately this one is not really that uplifting. I will be talking about people who have contracted PSSD, and many of them suffer great dysfunction either physically, mentally, or sexually in cognitive ways, and they are they are suffering and they are desperate. At the end, there will be a teachable activity that you can present to your clients or students. It involves eating a piece of gum, a piece of candy, but I will have non-food options. So the agenda today, we're going to talk about the goal and objective. I will define what PSSD is and iatrogenic sexual dysfunctions. And then we're going to go through like a typical story of PSSD. What I did, instead of just kind of trying to bombard you with facts, is try and kind of guide you as to what most patients experience. This is just so typical for many people. Then I'm going to talk about what you can do as sexuality professionals if you are if you're a medical professional, if you're a therapist, if you are an AASECT counselor, if you're an AASECT therapist or an educator. I'm going to specifically help you with what you can do in your field. Oh, and there's an activity that we'll talk about at the end. Okay, so the goal and objective. This webinar is to raise awareness about PSSD and similar iatrogenic sexual dysfunctions by helping sexuality professionals recognize the potential signs and what they can do to support their clients, patients, and students. So this webinar is not to discourage the use of medications. I'm not telling you not to take these medications, nor is this webinar is to provide the tools for a diagnosis. I'm not telling you how to diagnose PSSD. I'm telling you I'm hoping that you can be educated so that you can see the potential signs, or that if you have a client or patient who comes to you who says, I think I have PSSD, you will have resources and information and education to help those people. I like to joke that I am only related to medical professionals through marriage. I am in no way educated enough to provide you the tools to give you a medical diagnosis. I will show you areas where you can go to find that information, but this is not, again, not telling you not to take the medication. We're just telling you, hopefully you'll understand more about PSSD. So what is PSSD, right? And what is iatrogenic sexual dysfunctions, right? So PSSD is Post-SSRI Sexual Dysfunction or syndrome. There is a movement to call it syndrome now instead of sexual dysfunction because of the stigma that is coming with the word sexual dysfunction, or that people are just assuming it is only sexual symptoms and not the other problems that are happening. PSSD is not a disorder or disease. It is not something that you can get through genetically or from your friend. You can't get it from, it's not like you catch the flu. This isn't a virus or a bacteria. It's an iatrogenic condition. That means it is a condition caused by medical treatment. I had never heard of that word before. I had to go look it up. So it means that if you take medical treatment, either pills or maybe something like, radiation or chemotherapy, and then you have now symptoms because of that treatment. They were not there before. It is not because of some disease or because of the underlying disease. It is only because of the treatment. That's what PSSD is. PSSD can start during medication use, tapering off, or up to weeks after discontinuation. This makes it much different than most medications. Most disorders, not medications. It can begin after a few doses or for long term. And these, we like to not call it side effects. Like, this isn't the side effects of the medication. They're treatment-emergent adverse effects to describe the symptoms. I kind of just call them symptoms, because if you call them side effects, it sounds like it's a temporary thing. Like, oh, it's just a little side effect. Oh, you're a little nauseous or have some some headaches and it'll be fine. No. We're going to get into the list of the possibilities of what people can have. I'm going to show you everything, all of the medications, all of the treatments, all of the things that would bring you to the doctor, what medications you will take, and then what the effects could be. And anyone can have any of these symptoms. We'll get into them. But it's not like you have all of them. So we're going to talk about this typical story of what happens to a patient. This is just over and over again, you keep reading the same story. So the patient isn't feeling good for a variety of reasons, and they go seek medical assistance, as we are told to go do. Go see your doctor, right? You're not feeling good for any of these things, or somehow you want to feel a little better. Maybe you're not feeling that bad, but you just want to feel a little better. So maybe you have depression, maybe you have major depression, or you have seasonal depression. You have anxiety, PTSD or post-traumatic stress disorder, PMDD or premenstrual dysphoric disorder. You have eating disorders. Maybe you have schizophrenia, bipolar disorder. You have OCD, obsessive compulsive disorder. Maybe you want to stop smoking. You have insomnia and you want to sleep better. You have chronic pain from either fibromyalgia, diabetic neuropathy, or musculoskeletal pain. You might have interstitial cystitis. So any of these patients might have any of these things, the bladder, which is also called painful bladder syndrome. They might have IBS. They have acne. They're going through menopause, or they have prostate, kidney, or liver issues, right? So if you're a patient, so you put them in their shoes, you could have any of these things, right? Maybe you just have a little bit of depression and you're like, I just want to feel a little better, right? So let's go to the doctor, right? So you seek medical assistance, and the medical professional offers treatment, which includes medications, and the patient feels heard, right? They're like, great, this is great. I feel supported. However, the information given to them with their medication does not list all the possible side effects. It doesn't have PSSD listed on there at all. And they were not educated by their medical professional on the possibility of PSSD. So they go about their business and they start taking their medication. Maybe they were given an SSRI, a selective serotonin re-up inhibitor, or an SNRI, a serotonin norepinephrine re-up inhibitor. There's NDRI, norepinephrine dopamine re-up inhibitor. I am going to get tongue-tied many times throughout this webinar, but I'm just going to keep going, and I apologize for saying everything wrong. Tricyclic antidepressants, TCAs, antipsychotic, serotonin modulator and stimulator, and SMS. They might also be given other medications such as finasteride, isotretinoin, I know I said that one wrong, retinoid, and mirtazapine. And there's some other medications that we'll get into that they might be given. All of these, at this point, has been shown through evidence-based research to cause PSSD. So let's talk about each one and give you what each one is, right? So if they're given an SSRI, they're either given Prozac, Zoloft, Lexapro, Celexa, Paxil, or Luvox. They're given it for either major depression, general anxiety disorder, obsessive compulsive, panic disorder, post-traumatic stress disorder, social anxiety, bipolar disorder, premenstrual dysphoric disorder, chronic pain, insomnia, or IBS. So any of these reasons, they might be given SSRI, not just because of depression. Or maybe they're given an SNRI, right? Because that's also given for major depression, general anxiety, panic order, social anxiety disorder, and also for chronic pain. They're given either Effexor, Cymbalta, Pristiq, or Fedzima. Those are your SNRIs. So Trintellix is similar to an SSRI, but it's classified as an atypical antidepressant. It is also sometimes classified as a serotonin modulator and stimulator as an SNS. Wellbutrin. So talk about Wellbutrin or bupropion. I think that's how you say it. I always just call it Wellbutrin. So Wellbutrin is given to a lot of people instead of SSRIs because it is showing that sometimes it has less sexual dysfunction. However, for a lot of people, it has either caused PSSD or made their PSSD worse. So for this, it's given to people for, Wellbutrin is given for a lot of people for depression, for major depression, seasonal depression, but it's also given to people to stop smoking if they're bipolar, maybe they want to lose some weight, if they are obese. It is given to pediatric patients if they have ADHD, and if you have kidney or liver dysfunction, you might also get Wellbutrin. So TCAs are the tricyclic antidepressants. These are the first generation antidepressants. These are the pre-Prozac antidepressants. A lot of these are still being prescribed to treat major depressive disorder. Like if the SSRIs aren't working, they will go back to the TCAs. And also they were given for OCD, and they have found that it is helping people, amitriptyline is helping people who have interstitial cystitis, which is painful bladder syndrome. So I can go through these words in tongue tie: amitriptyline, amipine, desbramine, doxepine, imipramine, nortriptyline, propylene, blah, blah. I can't say the rest. You have them listed right there. The TCAs. So the antipsychotics, there are 3 types of antipsychotic. The first generation is your things like Thorazine, Prolixine, Arop, Compro, Stelacine, Haldol. If they have a little asterisk after these are available in the US. The generic versions are. So the wording might be a little bit different. Go to the medical word, I guess is the best way to probably look it up, because some of these are US and Canada are listed differently. Okay, antipsychotics. Second generation atypical antipsychotics. These are things like Abilify, Zekuato, Rexulti, Clozaril, Banipt, Captiva, Vitada, Black, Seroquel, Nuprazine, Risperdal, Geodone. Sorry about that. I told you I will be tongue-tied through these, but I've given you all of the information. So that is your second generation, and then the third or the next generation is Cobenfy. And these are your antipsychotics. So the other medications that I was talking about that are being listed not through evidence-based research have proven that these cause PSSD, but these same medications keep showing up over and over again in the forums where people are like, I know this is the only medication I was taking, or it had to have been that, or I know it had to have been this medication. And that is things like tramadol, which is a synthetic opioid given for pain, but it is it acts like an SNRI in a lot of people's bodies, and therefore is causing PSSD. There's mirtazapine, which is used to treat OCD. There's the neuroleptics, which are also known as antipsychotic medications. This is a class of drugs primarily used to manage psychosis, primarily in conditions like schizophrenia. And then there's things like Lamictal, which is an anticonvulsant mood stabilizer used to treat epilepsy and bipolar disorder. So maybe they got one of these medications, right? The patient was feeling a little depressed. Maybe they started an SSRI. And after a little while, they start getting some weird little symptoms that they can't really say are really associated with the depression. And they really don't understand what's going on. So there might be physical, sexual, emotional, cognitive, genital symptoms. And then their quality of life starts to get affected. So what I'm going to do is show you all of the possible symptoms that most people have reported. This is not the entirety of list, but this is the bulk of people have most of these symptoms or some of these symptoms. They won't have necessarily all of these symptoms. Kind of like a big buffet. You don't know what you're going to get with PSSD. So we'll talk first about the sexual issues, okay? Because it's called PSSD, sexual dysfunction, right? So most people, it's just sexual issues, and it is not. It's a lot more. So first, let's talk about those. There's a reduced or lack of sexual desire, libido, and sex drive, right? You just don't feel like having sex anymore. They don't have I'm like this. There's a reduced or lack of response to sexual stimuli. So what got them off before, got them all excited, is now not doing it. There's a reduced sensitivity to other sexual sensitive areas other than the genitals, like maybe your nipples, or maybe a little part on by the head neck or something that makes you a little tingly. Doesn't make you tingly anymore, and they're like, it feels blue or hurts. It's not right? And then their orgasms could be delayed, muted, or non-existent. They now might have anorgasmia, and their genitals just feel wrong or different. Something's going on down there that isn't right. There's a reduced sensitivity or numbness, which is often persistent. It's called PPTGH, a persistent post-treatment genital hypothesia. And this is the primary symptom of PSSD. So if you have a client or a student and a lot of their symptoms kind of seem to be all over the place and you don't know what's going on, and then they say, but my genitals also feel weird, then you're like, oh, maybe it's PSSD, right? So yeah, this is the main one that makes people go like, this is not anything else. This is what this is. This is a paresthesia, or a burning or prickling sensation. They might have that on their genitals. Like, it might not just be numb, it might burn. And they might have a decreased vaginal lubrication if they have a vaginal canal. If they have a penis, it might not work like it used to. They might have erectile dysfunction. There's a reduced or absence of morning erections. There is penis scarring in the erectile tissue. And there is a reduced or no nighttime erections or nocturnal emissions, right? So think about if you were a little depressed and you were a penis owner and you go get some medication so you don't feel so depressed. And now you don't have a penis that works. I think you're still going to feel depressed. Like, this is not going to help, right? They might emotionally start feeling worse, right? There's an emotional numbness or blunting, and they might have anhedonia, which is inability to feel pleasure, joy, or reward, but can feel sadness or depression. Let me talk about this for a second, because that little definition does not explain how awful this is. Many people are finding that this is the worst part of PSSD. because you're all of a sudden in a situation where you know you should be happy. Maybe you were with a loved one or a family member, and you know at this moment you should be feeling joy. Everyone around you is feeling joy, and you feel nothing, or you only feel sadness. And when the sadness comes, that's all you can feel. So you have no break from the numbness or the sadness in your life, and you know something's wrong. This just doesn't feel right. It doesn't feel like depression. They might have apathy or lack of interest. They are now depressed. There is a loss of romantic emotion. So the person they were romantically involved with, maybe they were a little depressed and they wanted to take pills so they would feel a little bit better and have a better relationship with the person they were romantically involved with. They now they don't feel romantic towards that person anymore. And they might not be able to feel empathy. They notice that they have cognitive decline, such as memory retention, delayed cognitive processing, disorganized thoughts, brain fog, right? They've got brain fog, basically. Difficulty communicating, inattentiveness. But they also have things like reduced creativity, lack of imagination and visualization, or aphantasia, which is an ability to voluntarily visualize mental images. And there's a loss of dreaming, right? They know something's weird going on. They might have some physical symptoms, like sleep disturbances and fatigue. Well, if you're depressed, that's typical, right? But maybe there's lighter or less frequent menstruations. They have also, though, their skin isn't as sensitive, and their senses seem less and their skin feels dry and wrong. Like things don't feel like it used to feel when you're touching themselves or when someone is touching them. They're just like, this isn't right. They might sweat more or less, or have urinary symptoms such as incontinence or frequency. Their ears might ring, and they can't regulate their temperature anymore. Now, these symptoms are one of the ones that I was talking about. Like if someone just noticed that they had these symptoms, they wouldn't necessarily think it was the medication. They might be like, well, maybe I'm premenopausal, right? My menstruations are less. Or maybe I'm just going through, hormonal changes or something that is causing all these things. Why would my ears ringing be associated with my depression medication when it wasn't listed on my drug info, right? And now, with all of these buffet of new symptoms, on top of the little depression that they might have already had, the quality of life is affected. Their self-esteem is down. They don't know who they are anymore. They don't know how to express themselves. Their mental health, their physical health, their sexual health is all like down the toilet. Their relationships are strained. If they had relationships before, they are now strained. And they are having problems entering and advancing in the workplace. And you're like, okay, these got to be side effects, right? Like that's what they call them, right? Like you're taking this medication and now you have all these weird stuff. It's got to be the side effects, right? So they go back to the drug information sheet. And I went back to the drug information sheet, to the Prozac website, and to the Effexor website in June, a couple of months ago, and copied what they had listed that would be any way associated with PSSD. Neither of them listed PSSD, but they did listed, Prozac listed there was sexual dysfunction in males with decreased sex drive, inability to keep or keep an erection, or delayed or absent ejaculation. There are sexual problems in females, which is a decreased sex drive, delayed orgasm, or inability to have an orgasm. Effexor said there are sexual problems taking an SSRI. You might have some sexual problems. That's all it said. None of them listed PSSD. None of them listed any of those cognitive, quality of life, physical, or mental symptoms that I caused. So what do, right? You call your doctor, right? You're like, well, I don't know what's going on, right? So your doctor then your medical professional has three options at this point. If the medical professional is informed about PSSD, they can treat you accordingly, and this is great. But the patient might not be informed about PSSD or sexual side effects, and that might cause more potential harm to the patient, right? They might get misdiagnosed with PSSD because the doctor is unaware of it, and starts a vicious cycle which harms them further, right? So let's talk about if the doctor does know PSSD and how to treat the patient accordingly. The patient will receive tests to rule out any other illnesses that could be causing these symptoms. As you can see, those symptoms are all over the place. And if you probably know, you could probably pick a few and list 50 other problems, medical issues that those symptoms will cause, right? So we want to diagnose, make sure there's nothing else going on, right? And then you can also be referred to talk therapy or other coping and emotional support professionals while the tests are going on, right? Even if you don't have PSSD, go talk to somebody about what's going on, right? There's some reason that you're not feeling good, right? The doctor can offer other medications that might help with general sexual dysfunction, but are not known to help PSSD, right? The patient feels less alone, they feel understood, and they now know what's happening in their body, but they still feel violated and lied to by the medical community. They were not given the information before taking the medication. So why would a professional not inform anyone about PSSD or sexual side effects? Maybe they don't have the time to ensure the patient understands the risk involved with this new medication. 12% of patients reported that they were being counseled regarding potential side effects while taking an antidepressant. 12%. Maybe the medical professional thinks PSSD is really rare and it doesn't need to be believed. It doesn't believe it, and they don't believe it's a real dysfunction. They're just like, I haven't heard of it. Nobody I know has it. It's not a thing. Nobody in my doctor has it, right? None of my people have it. Maybe they're seeing sexuality is not a priority to people's patients' health. They're like, whatever. You'll feel better. So what if you can't have sex anymore? At least you're not depressed anymore, right? That's how they'll say. There's a fear of non-compliance with the medication because of the sexual dysfunction risks. They know that maybe there's sexual dysfunction with these medications, but they don't want to tell the patient because they know if the patient won't take that drug because they don't want to lose their sexuality. So the doctor won't give the patient the information. This is not a theory. This has been proven through evidence-based research, and I have that on there. There's also just a lack of education and awareness. Many medical professionals just have not been told about this. The drug companies are not listing PSSD on all the side effects on the drug info sheets. So if the medical professional goes to the drug info sheets and it's not listed, how are they supposed to know that this is an option? This is a symptom that people could get. This is a lifetime iatrogenic condition. How do they get that information, right? Maybe they think PSSD is only a sexual dysfunction and that's not part of their field, right? They're like, well, I'm just going to help you lose weight. I don't help you with your sexuality. Or I'm only here to help you with depression. I'm not here to help you with your sexuality. They were never trained on sexuality and they don't know how to talk about it. They don't ask their patients about it. They don't bring it up. Sexuality research is not being funded, and currently sexuality is being attacked instead of being understood. So there's not more funding, there's not more research, it's not coming out more, right? The lack of discussions around sexual symptoms is causing PSSD to be widely underreported and underdiagnosed. Therefore, awareness and education are not available. Because it's being underreported and underdiagnosed, there's no funding, and so they're not getting the information, so the patients aren't getting the information, and everyone's suffering. The diagnosis. So if you're a patient with PSSD, you have to have symptoms for 3 months before you can be diagnosed to have PSSD. The diagnosis. So Health Canada issued a summary safety review of SSRI medications, issued a warning about the long-term effects and to sexual dysfunction despite drug discontinuation, and recommended that doctors warn patients about the risk. There's the website. The European Medications Agency acknowledged PSSD and added persistent sexual dysfunction to their side effect labels in 2019. The UK Royal College of Psychiatrists acknowledges PSSD on its website. However, the US has made no warning, and the FDA was sued over their failure to act. The US is not talking about PSSD. Diagnostic codes. The US diagnostic code for PSSD is not officially recognized in the ICD-10-CM, which is the International Classification of Diseases 10th Revision Classical Modification. So, if you are a medical professional looking for a diagnostic code, there isn't one. However, if you use the DSM-5, it does reference PSSD. In some cases, serotonin SSRIs. SSRIs induced sexual dysfunction may persist after the agent is discontinued. So it is saying that the symptoms continue after the medication, iatrogenic condition, PSSD. The MedDRA code. This code has been adopted by some organizations for PSSD. Please look this up, and there's a SNOMED CT code for PSSD. I'm not a medical professional. Please look these codes up before you put them on a diagnostic code. I am telling you, this is what I have found out through the therapists and medical professionals that I am working with. So PSSD, there was a diagnostic criteria developed by this researcher in 2022. And this is what it's saying. This is what they came up with to diagnose someone. That you have to have things either necessary, additional, or they should be. So you necessarily have to have prior treatment with an SSRI, but now there's more medications so excuse me. And there's an enduring change in somatic, tactile, erogenous genital sensation after treatment stops. So genitals are affected. Excuse me. And then there's additional things like there's loss of sexual desire. They might have ED. There's inability to orgasm problems, and that it's been problems for more than 3 months. Those things are additional. They have to have some of those things, and there should be no evidence of pre-drug sexual dysfunction, no current medical conditions that could account, and no current medications or substance misuse that account. So let's talk about if the patient is given a misdiagnosis. They go in for depression. They go back and they're like, I'm still depressed and I feel weird now. I have anhedonia and my genitals feel weird and blah, blah, blah. And they're like, So they have the same condition. They return to the doctor. Or maybe they have a new condition. They're like, I also have these other issues. Like I can't dream anymore. Like I don't know what's going on with that. And I'm not as creative as I used to be. So now the doctors will like, all right, let's talk about it. We'll treat your depression. We'll treat your creativity. We'll treat you're saying you also have insomnia. We'll treat those differently. So they treat it with different symptoms. It's being whole PSSD. So they're given more medications, right? Maybe they're given different. They're like, well, if your depression's still there, let's switch you from SSRIs to SNRIs, or let's give you a different medication, right? So they're giving you that. And maybe you're also getting now medication for the insomnia or the ears ringing or the bladder issues or the ED issues, right? So now you have extra side effects from those medications, right? Like, because they might cause nausea and headache and diarrhea, like the simple ones, but you didn't have that before, right? So now you have more symptoms, you're taking more drugs, and maybe you're taking a new SSRI that might cause your PSSD to feel worse. Maybe you start feeling more depressed and you have less apathy, and you're feeling now not romantic towards your partner, right? So what do? You go back to the medical professional and you're like, I don't know what's going on. Now I have more things, which might give you more medications, which might give you more symptoms, which might bring you back to the doctor. And you just keep circling, right? Vicious circle. And it has an effect on the patient, right? Years can go by before the patient receives a proper diagnosis. Years of getting the wrong medications, the wrong treatment, more symptoms, more problems, right? The patient may never find out they have PSSD. They may never attribute all of these symptoms. They might attribute these symptoms like aging, perimenopause, like your menopausal, your hormones are changing. Oh, I'm just getting old. That's just what happens when you get old. No, Maybe you have other illnesses and you're like, oh, well, that's it. My brain fog is because I'm already in chronic pain and have fibromyalgia, and I have already a list of all of those things. So how do I know that this is also PSSD, right? This is what this patient's going through. They might have started other medications before becoming sexually active, and they don't know how much it's affected. So they might have taken these SSRIs before they became sexually active. Maybe they were like 16 or 17 causing depression, or they were a child given Wellbutrin to help with the ADHD, right? How do they know if it's affect their sexuality? Because now, maybe in college or something, they're starting to explore their sexuality later in life. And they're like, oh, what's going on? Or maybe they took these drugs and saved themselves for marriage. And they go into marriage and they're like, well, why doesn't my junk work? Like then my genitals don't work anymore, right? So this is what is going on with these people. They know something's wrong. They know something's wrong, right? But there's no medical term that can seem to find the answer. And they just keep going in this spiral and everything keeps getting worse. And they're feeling more isolated and more afraid and a lack of trust. Because if they keep going back to doctor and doctors keep making it worse and saying, I don't know what the hell's wrong with you, you're going to keep feeling crazy, right? You're just going to be nuts. Like it's all in my head. What's going on? You're getting physical, cognitive, mental, and your sexual issues worse, right? Your quality of life keeps decreasing. So you're like, all right, I'm tired of this. The patient's like, I got to get off this medication. Or maybe they were feeling great. They were a little depressed and they took an SSRI. And after like a while, they're like, I can get off of this. I'm okay. Things are great, right? So for some reason, they go to the doctor. Either they want to get off the medication for any reason. They're like, I want to stop. Maybe the doctor's like, let's stop or reduce the medication, right? But most medications are given to people as either a capsule, little tiny beads inside, or a powdery pill, right? And we're not telling, and we're not giving these drugs, and the patients say, all right, go ahead and stop the medication. Just go ahead and wean yourself off. But they're not given proper instructions on how to wean themselves off, and how do you wean yourself off of one capsule or one pill. You like crushing it up and taking little corners and so but maybe they stopped the medication. Maybe they were feeling great. Like there's that one patient who took the SSRI because they were a little depressed. They were feeling great. They got off the medication and now they have symptoms. Now they have the physical, sexual, emotional, cognitive, genital symptoms, and their quality of life is affected. All of those things before, right? And then they go to those vicious circles. They start looking. Now, if they haven't done it by this point, the patient's online, right? Depending on their age, if they're older or younger, or how computer savvy they are, access to the internet, they might probably get online at one point, right? Because they're like, we're not finding answers through the medical professional, right? It might take weeks, months, or years to find the information on PSSD and similar iatrogenic dysfunctions. And if they do find this info, they return to their medical professional asking, like, what do I do with this? I think I have PSSD, right? Their doctors have 3 options now again. The doctors can be informed of PSSD and treat them accordingly, or they can be unaware of PSSD and misdiagnose and make them feel harder, or they don't believe the literature that the patient is bringing them, and the patient loses trust in the medical system. So we've gone over like what happens with the good stuff. Like if they're treated well, we know what happens, right? So let's talk about that medical misdiagnosis vicious circle again, right? Like if they're given, oh, well, it's not your depression. Now we'll treat your ears ringing and we'll treat, your bladder issues and this and this. So now they get more medications, they have more symptoms, maybe their depression gets worse, so they get more drugs. Maybe they go from SSRIs to SNRIs, and then those aren't working anymore. So they're given the TCAs and the antipsychotics, and they just keep getting more and more medications and more PSSD symptoms. What happens to the patient mentally with this? They're in a psychosomatic now vicious circle. Because if your medical professional tells you they don't believe the information, or it's all in your head, PSSD is nothing, or blames it on the depression. It's not PSSD. It's not a thing. You're just depressed. We're going to fix you up. You're just depressed, right? But the depression keeps getting worse, right? And they're given the wrong meds and treatment. They're given more SSRIs to treat with the depression, right? To improve the sexual dysfunction. They're given other drugs. They're given more antipsychotics. They're given therapy to treat their psychosomatic issues because the doctors are telling them it's all in their head. So they're going to therapy thinking they can fix themselves through all of these problems through therapy. They're trying to fix a medical condition by talking about it, which in this instance is not going to work. So now they have more treatment-emergent adverse effects, or they have new ones. Their PSSD might get worse. And now at this point, they just feel like they're a crazy person. They're like, I don't know what's going on. It's all in my head. I can't fix it. They're full of guilt and shame, and they don't know what's going on. Where are these symptoms coming from? What the hell's going on? They go down a vicious rabbit hole, right? If they find out eventually about PSSD, maybe they found the evidence, their doctor doesn't believe them anymore. So they're like, I'm going back to the internet. I'm going down the rabbit hole of PSSD, and they find out everything they can on it. They find out that 13% or 1 in 7 of past users of antidepressants reported persistent genital numbness after stopping medications. There is no mental health disorder that causes anesthesia of the genitals, whereas it is in a documented case effect of SSRIs. It's a documented effect of SSRIs. You can't, Okay. And up to 85% of the SSRI treated clients reported adverse sexual effects. So if you take SSRIs, 85% of those people said they had sexual dysfunction, not necessarily specific at PSSD, but definitely sexual dysfunction. PSSD is estimated to be highly undiagnosed and underreported. The longest reported case at this point is 23 years. In research, there are 6 different types of classifying adverse drug interactions. None of them clearly describe PSSD. It's all like medication that had side effects while you were taking it, and they went away at this point. And there's none that describe symptoms that occur after you take a medication that are caused by the medication and continue with no treatment available. So we'll get into that. They hear about PSSD in the news. They find a few people that did report about it. The BBC, Global News, The Guardian, the Daily Mail, the New York Times, and the New York Post. I have links to all of these articles for you. They find about other iatrogenic sexual dysfunctions, other dysfunctions that were caused by medical treatment. There is the PRSD, which is post-retinoid sexual dysfunction, or PAS, post-accutane syndrome. There's PGAD, which is persistent genital arousal disorder. PDOD, which is pleasure dissociative orgasm disorder. PFS, which is post-finasteride syndrome. Let's talk a little bit about those. And I have this little Venn diagram there because there's this big overlap where if you have PSSD, you don't necessarily have one of these. And if you have one of these dysfunctions, you don't necessarily have PSSD, but there is a huge overlap in the community. So they might have PGAD, which is what it sounds like. It's persistent genital arousal disorder. So they're just always aroused, always, to the point that it is painful. This is not a good thing for anyone. It's awful. Lamictal is one of the drugs that is directly associated with causing PGAD. They might have PDOD, which is pleasure dissociative orgasm disorder. This is a condition characterized by the inability to experience pleasure or satisfaction during an orgasm despite the physiological processes of an orgasm occurring. The patient may experience disassociation during the orgasm to awaken in a state of depression. PDOD may also be caused by other factors, including depression, addiction, hormonal imbalances, and physical conditions. However, PDOD POT occurs in individuals who have taken SSRIs, it may be a manifestation of PSSD. So this one is being looked into more. There's more research that needs to be done on this. So just to explain it, what happens is the patient says is like they are in the middle of a sexual intimacy with a lover or with themselves. And if you go like through the Masters Johnson, like just if we just say like use their sexual arousal little map as an example, like, you know, there's arousal and then you're going up to the orgasm and then you go to the orgasm and then refractory period, kind of back around. So if they're going up to the orgasm and they're getting super aroused and they get to that orgasm point, when that orgasm happens, we know that certain things happen physiological, like, you know, muscle contractions and muscle release and hormones are being released and there's all these feel-good chemicals that happen. What happens with PODD is that the muscles will contract and a lot of the physiological aspects will happen, but there will be no feeling of the feel-good chemicals. They will not feel the oxytocin, the epinephrine, all of the yumminess, right? So instead of you go through an orgasm and when you get to that point, the patient, instead of feeling good, will go into a disassociative state, into an empty hole, feel nothing, and then awaken in a feel of depression. Some people have said if you are into, or if you were practicing BDSM and you were similar to like a sub drop kind of a feeling where you feel like you have spent all of your serotonin and you are in a very black hole kind of a feeling. That's what happens with PDOD. PFS is post-finasteride syndrome. So finasteride is also Propecia. It is used to treat two conditions in men, either benign prostate hyperplasia, which is enlarged prostate, or it is also for male pattern baldness. It is an oral or topical cream can cause the PFS. Both. The symptoms are genital anesthesia, loss of libido, and sexual dysfunction. PRSD is post-retinoid sexual dysfunction. Also has the same symptoms of genital anesthesia, sexual dysfunction, and loss of libido. Isotretinoid is also marketed under these names: retinoid, Obscura LD. Accutane does not list it that way anymore in the U.S. Another medication. So this is for acne. Research. The patient is still researching online, right? They're finding all of this stuff, and then they're finding that there's very little research. And there's very many unanswered questions, and that people are asking for funding and asking for more awareness and education. There are so many hypotheses out there, and it seems like every week somebody is trying to come up with a new one. These have been some of the epigenetic gene expression. There's a dopamine serotonin interactions. There's serotonin neurotoxicity. There's hormonal changes. There are a few people trying to do research in this, but at this point, there's really nothing that seems like it's obviously the answer. So what about reducing or stop medication? They found out that when they were told to taper off, they should have tapered off very gradually, and they could have gotten their drug in a liquid form, and that way they could use less and less drops slowly over months and not trying to get off of medication in 2 weeks to grinding up some pills or something. They find some websites and they find some online support. There's Canada PSSD. There's Reddit R PSSD, which had 16,000 members a couple of months ago. It's growing every day. There's tons of people in there who will help you and research and show you where to go. There's a PSSD network, the PSD, German PSSD, the UK PSSD, the Italian PSSD. There's the PSSD forum. There's a Discord, there's a Twitter, and there's a WhatsApp. So whatever you're most comfortable with, the patient can find some support. And they find community, right? They're like, oh, I'm a Discord user. I can go on Discord and I find a whole group of people who understand me. I go on Reddit every day. I can just go on there and people can support me and help me. I feel like I'm not alone, right? And they find out it's not all in their head, that it is a condition. It's an iatrogenic condition, right? They find support, they find connections, they find out that this can affect anyone, regardless of age, sex, ethnicity, income bracket, or what illness or treatments they had before. This is not like you had cancer when you were a kid, you're going to get it again later, or somehow because you had scarlet fever, you now have PSSD. There's nothing in your past. Even if you were depressed before, as much as anyone can be depressed, nothing has caused the PSSD except for these medications. And they realize that they didn't do anything wrong. And they can't fix it themselves. No amount of therapy can fix it. Therapy can help, but therapy can't fix it. It's not in their head. And they find out, though, that these treatment-emergent adverse effects could last forever. Many people have windows, some have crashes, where they have a window of relief, the symptoms improve, but then resolve, right? It's this little window of relief that usually happens when they have a new medications or symptoms, sometimes with or without a trigger, or they can have crashes where all of a sudden everything is just really worse. They find out that other people say there is no medical treatment or recovery at this point. There's none. Some people have recovered or seen improvements after years, some have not, but there is nothing that is showing evidence-based that works. Some people are given treatment with Wellbutrin. They were given bupropion as an option for the SSRI, but again, they're finding that this might have causes more issues, and a lot of people are saying this is how they got PSSD, and so not safe. They start having their fears. The fear, if it hasn't been before, is now definitely there now, that they feel alone in this drama, that they won't get any better, they have a lost sense of self. Their support community will burn out and give up on them, so they will be completely alone. They won't be able to have relationships, family, or children. If they're certainly single, it is hard for them to date at this point. They are unaware if they can even maintain a relationship, and they have to disclose this to someone. Hey, I might not be attracted to you, or I might not be able to do things sexually because of, taking a pill. They might not be able to work or provide for themselves. They'll be dependent on other people. They won't have love. And they find that they're scared that it is untreatable and that pseudo ideations are present in many. So you have to tell everybody around them, right? Do they? And if they do, it's like, hey, it's hard to communicate the experience and the impact on their lives to others, even those who might be very close to them. Medical professional society and patients are all uncomfortable talking about sexual issues. Just as an example, I am a person who has lived with chronic pain for 20 years. I have seen, I don't know how many doctors at this point. None have ever asked me about how my chronic pain affects me sexually. It's not brought up. They might not be comfortable talking. Patients might not be comfortable talking with their family and friends about their sexual problems and health issues. Hey, 85-year-old dad, I now have anorgasmia. It's kind of hard to say. They might have to tell existing lovers their PSSDs forever. And what does that relationship look like now? What if all of a sudden you're like, I'm no longer attracted to you or feel romantic feelings for you? How do you tell this to a lover? How do you tell this to a new lover, right? Or a potentially new lover? And you have to hope that they will believe you and understand how impactful this is. And all this is going on, you're still having sexual struggles, right? And you have ongoing sexual struggles now. The patient might have to learn how to be sexual again with their existing partner. Things are different now. Things feel different now. How do you have the same sex? Difficult to concentrate during sexual acts. They might wander off and disassociate if things didn't feel as good as it used to feel. Be reminded of what they had before. Their lover might feel unwanted, unloved, or not be able to satisfy them as they had done before. If all of a sudden their partner, their lover the patient is now anorgasmic, and their lover is loves giving them orgasms, and that's not on the table anymore, that will affect the relationship. The orgasm that was once a release, it may be weak or gone. They may have to learn how to stay present now during sex because they just disassociate or wander off. And even solo sex might be something the patient no longer wants to do or is even traumatic now. Because solo sex maybe used to just be like, knock one out and a release and feel it great, feel a little stress, tension. And instead now it is not. It's the opposite. They have ongoing and new struggles now. They're trying to develop and maintain relationships due to anhedonia and emotional blunting. They no longer feel the emotions, love, empathy, compersion, or romantic feelings towards their family or friends. They are forced to depend on others. There's a loss of self and future goals. There's a fear of any new medications and afraid of the medical community. And their healthcare is compromised as they may refuse regularly yearly checkups, pap smears, etc. They may only go to the doctor if it's an emergency. They still might be suffering from the primary reason with the additional symptoms of PSSD, right? They might still be depressed and now have all this extra stuff on top. And then finally, they're like, screw it. I'm just going to become my own medical professional. And they go into that rabbit hole and they don't trust any medical professional anymore. They look online, they go to forums, they seek treatment from what other people have done. They experiment with medications, whatever they can get their hands on. They have learned and been told to lie to doctors to get certain medications, and they're trying illegal ones just to get any kind of relief. They try natural agreement treatments, but they find it doesn't work. Things like ashwagandha, I know I never say that right, and seitan worts have caused PSD for some people, and even microdosing psilocybin is not helpful, and some people have had crashes from a microdose or a macrodose. So this is my personal summary. After being on forums and reading about PSSD since 2019, 2020, I believe now, there's kind of like these three phases of acceptance that I see on the forums. So first I called it like the child. They have found out they have PSSD and they are desperate to find answers, right? They're like this little kid. They're like coming up with theories. They're processing all this new information. They're confused. They're extremely confused. They don't understand what's going on with their body or themselves. And they're just like, little baby, little toddler, just, right? So finally they kind of grow up to a teenager after a little while. They're still They're still seeking treatment and they're still desperate. However, they are kind of taking out what everyone said what would work, even if they kind of had to lie to get it. They might be seeking some treatment. They're desperate for any kind of a treatment. They're like a teenager willing to experiment at this point, right? Like kind of used to rebel teenager, and they are angry, and there's no trust in the medical community, right? Like an angry teenager who just thinks their parents are the idiots, right? Adults are idiots, right? That's how they are. They're pissed off. Okay. And then they kind of move into like this adult phase is what I call it. And it's kind of like there's this level of acceptance of like, okay, this is how my life is. I've learned to kind of like adjust. I'm still like, maybe learning, and I don't want to be silenced anymore. I don't want to be that little kid anymore. I want to like try and help others who are maybe seeking community and support. I know what they're going through. I've been going through it. And they bravely share their story, but they are still desperate for treatment, support, and hope, and they are still really angry. I am prevalently on Reddit. That's my social media that I kind of go on a lot. I am even a moderator of a small subreddit. I am on reading these often. These forums are different. Like even the chronic pain and stuff, it's like there's still like some happy memes or some jokes here and then and stuff. There's no jokes on here. These people are pissed off. And if you make a joke or if you say something just the slightest bit, they are all jumping down your throats. These people are angry, really, really angry at the medical community because they took away their consent. As sexuality professionals, we talk a lot about consent. Like there's fries, there's enthusiastic, there's risk aware, there's a million ways we talk about consent. We have numerous webinars we can go to, books on consent, how important it is, right? But yet the medical community gave us all of these drugs and gave the patient the drugs, but did not give them the information so that they could consent. They could not say, I am risk aware that these medications could affect my sexuality, affect my physical and mental cognitive health, and I am willing to take them because I am willing, to take those risks. But they're not allowed to do that because they were never given that information. So what is you, as sexuality professionals, can do if you're a medical professional, if you're a therapist or an educator? If you're a medical professional, this is what we ask of you to do. We ask you to create an open environment. It's okay to talk about sexuality. Please bring it up first because patients are afraid to do so. Talk about informed risk consent and risk-aware consent. Talk to people about PSSD so they know the risk before taking the medications. And then when they're taking those medications, or if they're about to, do a baseline sexual functional assessment and then document anything that have done pre-existing or any changes while they're taking this medication or in their medical history, and then monitor their sex life, monitor any changes. And we ask it that you recognize and validate, confirm that PSSD is real, validate their emotions because the patients are going through a lot of grief and anger, and it is normal for this. And tell them that this is normal. Emphasize that this is not their fault and acknowledge that grief is to be expected and worsening medical health is very common in this situation. Recognize the potential for feelings of self-blame and betrayal, especially since many patients were not warned, and avoid minimization. We're asking you also to report PSSD. And even referrals help raise awareness in the medical community about PSSD and help patients feel like their concerns are being taken seriously. Again, we've always said I feel like it's very highly underdiagnosed and underreported at this time. You can refer them to the patients to therapists and specialists. Ensure mental health providers that they are educated refer to therapists and specialists who are aware and educated on PSSD. Refer to sexual medicine, neurology, rheumatology, urology, and endocrinology to help them possibly take medications that can help with the symptoms of PSSD. Sex therapist. If you are a sex therapist, this is what we were asking. We are asking that you are not there to treat patients medically, but to recognize the possibility of PSSD, help manage psychological distress, and support people to grieve the loss of their sexuality due to a non-consensual act, and help patients process the ongoing trauma. Patients have no one else to talk to about this, and often it is very hard to talk to anyone about this, especially their lovers, family, and friends. Try to articulate and reflect back to them exactly what they're experiencing. Many have had pushback from other healthcare professionals. They may be very afraid of anyone who is in the medical professional. Even if you're a therapist, they may associate you with that community and be afraid of you. We want you to show deep curiosity, be inquisitive and empathetic, and demonstrate a true desire to know the truth of any of the condition. Show authentic interest is essential. So for you educators out there, the educators are not here to provide therapy or provide medical assistance, but to be informed of PSSD, spread awareness of the iatrogenic sexual dysfunctions, and work with your clients to provide the sexual education and resources. Help those connect back to their body, to their sexuality. That's what you guys and I'm an educator. That's what we're trained, right? We can refer them. We can find, I have a list on the handout of all of the resources that you will need. Help them turn up the volume on what little pleasure they experience and focus on, or they can focus on their lover's pleasure. Maybe that can give them some satisfaction or a feeling of they are still in the relationship. If they can't focus on their pleasure, maybe they can focus on their partner's pleasure. So what can the patients or students do, right? Like, what can they do, right? They can report PSSD to regulatory agencies such as Health Canada, Adverse Event Reporting, and FDA, report their PSSD to the manufacturer, share their experience to raise awareness. Some options include the PSSD network. There is a YouTube interviews with Dr. Joseph Whitdoring, and there's PSSD Canada patient stories. You can also contribute to research funding efforts. The PSSD forums and events, forums and Reddit, you can find a lot of what the patients can do. So what do the patients need? They need awareness, research, education to medical professionals, education to healthcare, mental health professionals, treatment, support, media attention, and hope. So I want to just make sure that you understand that not everyone has those same side effects. Like all of this listing of what I have, there's just a buffet, right, of PSSD. So work with your clients, your patients and students, and to find out what tools they have. What problems are they having? What symptoms are they having? So that's what you guys can do, and that's what your patients can do. So now I'm just going to give you this quick little activity that I have developed. It's kind of based on a cognitive brain, a CBT therapy exercise, but it just kind of slightly modified. I have been doing this myself for years to have a very slight improvement on my PSSD, but very, very minimal. But this can be something that I think can help someone kind of connect a little bit more with their body, connect back to their pleasure possibly, or connect to their partner's pleasure. And or it can maybe help just kind of think of a tool that you could use. Like this is, if don't have to use this exact tool, modify it for your patients and figure out what they need. Okay, so this is the activity. This is what I was talking about. I have PSSD, POD symptoms, and this is what kind of I came up with. So this is about focusing back on your senses, being in the moment and focusing on any kind of pleasure that you're having. If we have this much pleasure, can we focus on it so it feels a little bit better? Can we keep doing that? Can we keep retraining our brain and getting those pathways back to pleasure? So some of the senses are sight. So what we're going to do is we're going to have an item. It's either going to be a food, or it can be something you can hold in your hand, or it can be an imaginary item in your head, just anything. So we're going to go with sight, which is looking at an item, touch, which is physical sensations, hearing, which we're going to either hear things out loud that are outside of our head, or we can hear narration inside of our head. There's smell and taste, and if imaginary, you can always imagine smell or taste like. There's emotions. We can use a funny voice when we narrate to have a funny emotion. And there's also body awareness, what is touching that body, how am I touching it, where is it? There's the senses of balance, of where we are in the world, and there's creativity and imagination, and there's more senses. These are just a few. So just kind of go back to the senses. So this is the instructions. So we're going to take a piece of candy, or you can take any kind of food, or a piece of water, and kind of put it in your mouth. I like to use candy that's kind of a little strong, maybe a cinnamon candy or a peppermint, something that kind of wakes you up and you really notice it. And if you don't want to use any food, you can just imagine anything. I like to use something that is completely imaginary and not associated with a memory. I have a Pegasus unicorn standing at the top of a mountain, flying through a rainbow. I have no memory or emotion attached to this. It's just something random. So, or you could picture a purple apple or something, just nothing that makes you feel sad, or that's not what we want. Okay, so now we're going to put the food in our mouth, right? Or we can like look at it first. Like, what does it look like? What is the texture like? What does it smell like? Like, what does it taste? Is it rough or soft? Does it melt in my mouth? Like, how does it feel on my tongue, on my teeth? Like, what do I have to do to move it around? You have to like move your head or swish your tongue, or like, what are you doing? Okay, that's the food. Now, if you have an imagination, you're trying to focus on your imagination, not like on a piece of food or something. You can like think about it, like, what does it smell like? What's the texture like? Is it moving? What is it doing? Is it alive? Is it old? Is it new? Like, how does it make you feel? And then you can bring in a sense of play. Like I was talking about how you can narrate so you can hear what's going on in your mind. Like, you can narrate the candy in your mouth. And you can do this with an example, with a bunch of different characters, just to kind of have fun and take it into a pleasure thing. Like, if you're a 40s gangster, you could be like, oh, see that candy, see, it sure is hard, cutting against my teeth. Or a Southern belle, like, oh my, I can't believe this candy is so strong. Or a hot dog vendor, like, get your candy here, $2. You can just play, right? I have examples of like, how would an alien be eating a candy for the first time? Like, boom, 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 boom. Like, well, what does the doctor say? Like, oh, candy's so good, right? Like, just pro wrestler, announcer at a baseball game, like an animal or a butterfly. How would you imagine an animal eating? Anything you can think of, any voice. This is just for fun. This is play. This is pleasure. This is trying to bring any of this back. You can dictate to your inner secretary while this is going on. You can like write a story or a journal or a movie or anything that's going on, or some romance novel, right? Like, here's the example of like, I came up with like the sour candy in my mouth caused me to salivate so much that the drool was dripping out of my mouth over my gorgeous red lips. Like, this is some hot romance, sexy novel that you could come up with, right? What if you used this during sexy time? What if you started to narrate, instead of the candy in your mouth, the sensations of what were going on, so you were double focusing on it? Like, you could feel what was going on, but you're also narrating it and kind of having fun and in a playful way. Like, what is being touched? What is being touched to me? What am I doing? What if I'm with a lover? What are they doing? Like, with what? How hard, soft, fast? Like, what is the rhythm of it? What is happening next? What do I want to happen next? What happened before? Like, all of this can happen, right? You're focusing on the pleasure and you're not focusing on the PSSD. And that's my little tool. This is what I do that helps me out. So how can you develop it to meet your clients' needs? Because I know there's a lot of you out there who are much more intelligent than I am. So here are all my resources that are also on the handout for you guys. We're coming to the end of our presentation. It was a little bit over an hour. And so I have all of this on the stories. There are resources. All of these links are here. These are the references of all of the web pages that I went to about the food and the drugs. Here's more information about all the drugs. Here's all the news articles where PSSD has been mentioned in the news, and my many pages of evidence-based research that has gone into this webinar. So I want to really, really thank you for watching the webinar and becoming educated on PSSD and similar iatrogenic sexual dysfunctions. We're asking that you please help raise awareness. You can reach out to me at any time. This is my email address. This is my web address, my website. If you would like to join Yassi's meeting where they talk about their caseload of PSSD clients, you can email her directly or myself. If you have any questions with this webinar or have any issues with the test or handout or anything, just give me a call or email. I really appreciate it again, and thank you so much.